T minus 1 minute. T minus 50 seconds. T minus 40 seconds. T minus 30 seconds. T minus 20 seconds. Ten, 9, 8, 7, 6, 5, 4, 3, 2, 1, 0.
Good morning, everyone. We are your moderators for today. I am Mr. Enriquez R. Cayaban,
I am
training,
Darwin.
training officer of Santiago Medical City.
I am Darwin Milian Garnes, IPC officer, Santiago Medical City.
Good morning, Santiago Medical City. We are currently in a virtual training on ECG interpretation. Just to give you background of our topic today, ECG is significant diagnostic tool to check the electrical conduction of the heart. And if certain ailment is discovered, prompt remedies will be undertaken. That is why its early detection is so important.
Good morning, visitors. We would like to thank the following participants who are presently tuning in our virtual session. Let's give them a virtual applause to Santiago Medical City, Flores Memorial Medical Center, Callang General Hospital and Medical Center Incorporated, Rivera Medical Center Incorporated, Adventist Hospital, other medical professionals, nursing students of University of La Salette College of Nursing, Northeastern College, College of Nursing, University of Isabela State University College of Nursing. Thank you for now that you have spent time for this event.
Welcome to the webinar titled Basic Cardioelectrogram Interpretation. The goal of this training course is to equip our nurses and other nursing staff the knowledge and skills in recognizing normal and abnormal ECG patterns and what immediate interventions can be done to prevent the adverse events. To have a smooth run of the webinar, there are set rules which define etiquettes during virtual activities. Sir Darwin M. Viernes, RN, LPT, NEN, our IPC officer will enumerate the following house rules.
I have the honor to present to you the different house rules during the conduct of this webinar. First, see that there is no disturbance like background noise or people moving around to avoid distractions. Sit in a good lighted and noise-free room. We encourage you to use earphones to fully enjoy the learning process. Second, check laptop or desktop before joining the webinar. Kindly choose a spot with unlimited or strong internet connection. Ensure data availability to avoid disconnection during this webinar. Third, please put your microphone on mute and camera on off during this session to avoid interruption during this webinar. Do not close or leave the Zoom app during the session to avoid being logged out, which will result in incomplete attendance. Fifth, if you have any questions about the presentation or topic, you may type your question on the QA box that the moderator can take note of it. The questions will be forwarded to the respective speaker. Keep your question minimal and related to the topic. Make sure to put your real name, full name, anonymous name will be disregarded. 6, in case of technical glitches, kindly send us a message via email, enriquezcayaban90@gmail.com. State your name and your concern. 7, accomplish the evaluation form to redeem your e-certificate. QR code will be flashed on the screen. You may also check the link on the chat box. Lastly, no video recording will be available to those who failed to attend this synchronous session of this webinar. Thank you. Let us all feel the presence of our Almighty God for this opening prayer.
Good morning, Lord. Today's a new day, a chance for a new start. Yesterday is gone, and with it, any regrets, mistakes, or failures I may have experienced. It's a good day to be glad and give thanks. And I do, Lord. Thank you for today. A new opportunity to love, give, and be all that you want me to be. Today I want to start the day with you on my mind and in my heart. As I dress, let me wear the armor you've provided daily, the helmet of salvation, the breastplate of righteousness, the shield of faith, the belt of truth, the shoes of peace, and the sword of the Spirit, with prayer on my tongue, praise for you, and petitions for those around me and those I meet. Feed me today with your daily bread, as the bread of life. Your food, like manna, will sustain me throughout any trials and hungers. Help me to set my thoughts on things above, and to speak only what will help and encourage others. Keep me from putting my foot in my mouth, and help me guard the affections of my heart today, Lord. Make whatever work I do be marked with excellence rather than perfectionism. As I seek not to make a name, but to make a difference. Help me to treat each person I encounter as you would, with respect and love, forgiving others and asking for forgiveness myself when needed. As I start this day, help me remember that I belong to you, and my desire is to act accordingly. Keep my feet from stumbling, and my mind from wandering into distractions that could steal precious time and energy from the most important things you have designed for me. I'm proud to be your child, Lord. And I'm so grateful that you died for me, rising again so that every day could be filled with the wonder of your love, the freedom of your spirit, and the joy of knowing you. I know earthly life is short and fleeting, Lord. But I want to live today as if it were the first or the last day of my life, giving thanks for every good and perfect gift you choose to give today and every day. I want to live my life for you, Jesus. In your precious name, I pray. Amen.
To hear an encouraging and inspiring welcome remarks, I will give the line to Dr. David Calvin Ko, the Training Officer of the Department of Internal Medicine at Southern Isabela Medical Center.
Hello, good morning.
Good morning, Doc.
Morning, Doc.
Actually, I'm excited for this activity of yours, for piloting this kind of activities. I'm surprised na lahat I'm surprised that we invited other hospitals to join us with this endeavor. So I chose a good speaker whom I really trust, Dr. Mariano, our Chief Resident from Southern Isabela Medical Center. Sa tingin ko kasi mas maganda yung age bracket ni mas malapit compared sa akin. Pero I will be here supervising the activity, and if my question, you can throw us your question, and hopefully we can answer your questions accurately. So this basic ECG interpretation, just what you've said kanina, Sir Kayaban, importante talaga kasi for us na physicians, kayo kasi ang mata namin sa hospitals. So with full trust talagang sa inyo rin kami nagre-rely. Sabi nga nila, walang doktor kung walang nurse. Okay, so thank you for attending this session, and without further much ado, welcome to
Thank you, Doc Kiko, for that warm welcome.
It is not uneasy to introduce a certain person. However, to give a humble background to our resource speaker for today's webinar. Let us all witness the academic track, clinical journey, interests, and achievements of our resource speaker for today. I will give the virtual floor to Sir Enriquez Cayaban, RN, LPT, MAN, to introduce our guest speaker. Thank you.
It is my utmost privilege to introduce our guest speaker for today's webinar on basic ECG interpretation. He is a full-blooded Isabelino and is currently residing at Osmeña, Cordon, province of Isabela. Based on his academic track, he finished his primary education at Cordon Central School on the year 2002, and after 4 years of hard work, he successfully completed his secondary level at St. John Birchmans High School. He pursued his tertiary education at St. Louis University, Baguio City on the year 2006, taking Bachelor of Science in Nursing. He was Agawad San Luis awardee during his baccalaureate ceremony because of his love to music, being the conductor and also a promising singer of a choir group. He finished his undergraduate course in nursing on March 2010. On the same year, he earned his license in nursing after passing the nursing licensure examination on the month of July. He had his more than a year clinical exposure at the Veras Medical Center as a staff nurse. Then after that, he became the project officer of the Movement Against Malaria program under Filipinas Foundation Incorporated from 2011 to 2013. His interest to medicine and life brought him to a decision to continue his passion in caring community people as a future doctor. At the same school where he finished his bachelor's degree, he pursued Doctor of Medicine from 2014 to 2018. He was awarded as one of the most outstanding students astute in clinical clerkship because of his outstanding performance in clinical duties. A month after the graduation, he formally started his postgraduate internship at St. Louis University Hospital of the Sacred Heart. His training lasted for a year. Because of his excellent performance in clinical area, he received various recognitions as most outstanding intern in the different departments such as internal medicine, OB/GYN, and surgery. September 2019 was the moment when he victoriously passed the physician licensure examination. Presently, he is the Chief President of Department of Internal Medicine at Southern Isabela Medical Center. He also engaged in numerous activities such as HIV, peer education, and member of Committee on Productive Health and HIV and AIDS. A very talented doctor in town, a nurse, a physician, a musician, a singer, an educator, and many more. I know there are a lot more nouns and adjectives to describe this person. So without further ado, I will now give the line to Dr. Christian Mark B. Mariano. Let's give him a virtual round of applause. Thank you.
Thank you, sir, for that very wonderful introduction. And thank you to my ever supportive and stellar training officer, Dr. David Calvinco. So I hope this lecture will be very light and very interactive between me and the participants. So feel free to ask your questions, and hope our lecture goes well for today. Okay, so sir, I will just be sharing my screen na, so that we can start na the lecture.
Yes, Doc.
Is the audio clear, sir?
Yes, Doc. Clear po.
Okay, thank you. Okay, so again, for today, we'll be having a lecture on basic electrocardiography interpretation. So with me is my training officer, Dr. David Calvinco, and I am Christian Mark Mariano. So for the objectives of our lecture, first is to discuss basics of electrocardiography reading and to be able to identify normal ECG findings, to be able to identify the most common ECG waveforms needing urgent management. So first, to start the lecture, we'll be discussing the basics on ECG. First is to check for the standardization of your ECG strip. So the standard calibration is 25 millimeters per second and 10 millimeters per millivolts for the height. So for the speed, it's 25 mm per seconds and the height 10 mm per millivolts. So this one, ito yung lagi nyong sina-check dun sa strip after printing your ECG. So make sure that the calibration is correct. On the vertical axis, yun nga, 1 mm, yung each small box is 1 mm on the vertical axis. So 10 small boxes is 10 millimeters or 1 millivolts. And on the horizontal axis, each small box is 0.04 seconds. So in 5 small boxes, we have 0.2 seconds, which means that 5 big boxes containing 5 small boxes each is 1 second. So in ECG computations and interpretations, nakabase siya dun sa standard ECG calibration na 25 mm and 10 mm per millivolts. Okay? So the waveforms and intervals that make up the standard ECG are displayed schematically on this figure. So the P wave, which is generated by the activation of your atrium, and the PR interval corresponds to the duration of your atrioventricular conduction. So when your atrium magka-fire na yung sinoatrial node, that's when your P wave will be generated. And followed by the QRS complexes, which is produced by the activation of your 2 ventricles. So when your atrium contracts or nag-fire na siya ng conduction papunta sa ventricles, then pag nag-contract na yung dalawang ventricles niya, that's when your QRS complexes is generated. Kaya makikita niyo meron kayong QRS complexes na positive waveform or paakyat yung wave niya. Kasi that's when your ventricles contract. And last is the ST, T wave, which reflects your ventricular recovery or the relaxation of your ventricles. So that's what makes up your complete ECG or the ECG waveform. So your P, your QRS complexes, and your STT wave areas. Next are your ECG waves and intervals. So this is just nice to know. Your P wave is the sequential activation or the depolarization of your right and left atrium. And your QRS complex, just what I have said a while back, the right and the left ventricular depolarization, or normally the ventricles are activated simultaneously. That's when your ventricles contract, nag-generate yung QRS complex. And the STT wave during your ventricular repolarization or the relaxation of your ventricles. The PR interval is the time interval from the onset of your atrial depolarization or the activation of your atrium to the onset of your ventricular depolarization. So from the time na nag-fire yung SA node hanggang mapunta siya sa ventricles and mag-contract yung ventricles mo, that's your PR interval. Yun yung time na yun. And the QRS duration is the duration of the ventricular muscle depolarization or the duration ng contraction ng ventricles. And the QT interval is the duration of your ventricular activation, yung contraction hanggang sa relax yung inyong ventricles. That's the QT interval. And the R2R interval is the duration of your ventricular cardiac cycle.
Excuse me, Doc. Doc Mariano.
Hello? I'm so sorry, mukhang na-disconnect yata.
Isum na lang
Hanggang
po
saan
natin.
okay kanina, sir?
Dun po sa nice to know yung mga...
Intervals. Hello, sorry. Nandito ba tayo kanina nung naghangsa? Sorry.
Doon tayo
Yes,
sa
Doc.
RR interval.
Okay, so ay nandito tayo, Doc, no? Sa RR intervals.
Yes.
Okay, thank you, Doc. So your R2R interval is the duration of your ventricular cardiac cycle or the indicator of your ventricular rate. So the R2R interval, mamaya ituturo ko, dyan natin makukuha yung ating cardiac rate. And of course, these ECG waves and intervals may be variable depending sa patients natin. So variability between individuals may reflect differences based sa age, gender, race, body habitus, and even the body physiology of our patients. So going to yung pinaka-important part ng ating lecture, which is ECG reading. So ito yung outline on how we are going to read our ECG. So first is we determine the rates, we determine the rhythm, we determine the axis, we measure the intervals if needed, and check for chamber enlargements, check for signs of ischemia or infarction, and check for miscellaneous findings or abnormal findings in our ECG. So first is we determine the rates. So for us to determine the rate, we have to check yung R2R interval, yung sinasabi ko nga kanina. Okay? So in determining the rate, itong unang ituturo ko is for ECGs with regular rhythm. So kapag pantay-pantay yung ating R2R interval. So if you can see this one, that's the R2R interval. So dalawang QRS complexes yan. Then with this, we will be counting yung small boxes between the R2R interval for us to determine the heart rate of our patient. So with this ECG strip, we have 18 small boxes. So what's constant here is the 1,500 na numerator. So 1,500 divided by the number of small squares from your R2R, the answer is 83. So 1,500 divided by 18, that's 83 beats per minute. So kapag nakakita tayo ng isang ECG strip, for us to know yung heart rate ng patient na objective, kasi minsan nakalagay na doon, di ba, yung heart rate ng patient doon sa ECG. Pero kung bibilangin talaga natin sa, what we do is 1,500 divided by the number of small boxes between your R2R interval. So that's 83 beats per minute for regular rhythm. Next is we determine the rhythm. So sabi niya, rhythm is determined by the sinus node. So our sinus node fires at 60 to 100 beats per minute. So that's yung normal range ng ating heart rate, which is 60 to 100. So the P wave is normally upright. Makikita natin siya sa lead 2 and usually upright din siya sa leads 1, AVL, and your AVF. And each P wave is followed by a QRS complex, and each QRS complexes is preceded by a P wave. So dapat yun yung mga criteria natin for us to say na yung ECG natin is sinus yung rhythm niya. Otherwise, hindi siya sinus or merong abnormality sa ECG natin. And the distance between your R2R intervals should be equal. So if you can see this ECG strip, makikita niyo siya. Yung parang tinuro ko kanina, yung first na deflection sa ating ECG, upright deflection, yung maliit na P wave, yan. With the red arrows, P waves, makikita natin siya. So yun yung mga P waves natin. Nakikita niyo ba? Ito, yung mga P waves natin. Hello, sir?
Yes, Doc. Apa.
Okay, sige. Akala ko nawala ulit. So that's the P wave and followed by your QRS complexes. Wait lang. Ano ba? So ito. These are your P waves. Nakikita niyo ba yung in-encircle ko?
Apa, Doc.
Okay. So, yun yung mga in-encircle ko, sila yung mga P waves. So, if you can see, marami tayong dyan. Lahat ng strips natin, meron siyang P wave. So, dyan natin malalaman na sinus yung rhythm ng ating ECG. And sabi sa criteria, each P wave should be followed by your QRS complexes. So, the QRS complex, ito naman siya. Okay. So, very regular yung ECG natin. And each, sabi din niya, the R2R intervals should be equal. So, equal din yung mga R2R intervals natin. Pantay-pantay siya. So, kapag nakita natin na merong P wave, yung P wave is followed by a QRS complex, tapos each R2R interval is regular, then we can call the ECG strip as regular sinus rhythm. So, yun yung pinaka-umpisa plus the rate. So, una, rate. We identify the rate by counting the R2R interval small boxes, 1/5 divided by kung ilang small boxes, and then followed by the rhythm, kung sinus man siya or hindi siya sinus. So, alam na natin kung sinus siya and alam na natin kung ilan yung cardiac rate ng patient natin. Next is, yung una kong tinuro kasi kanina is determining the rate during your regular sinus rhythm. Pero meron tayong mga ECG strips na minsan makikita nyo hindi regular yung R2R interval. So your SA node or your sinoatrial node can discharge irregular conduction. So minsan nagva-vary siya depende sa respiratory cycle ng patient. The rate may be normal, nasa 60 to 100, but the rhythm varies with respiration. So there is variation between your P2P interval and your R2R interval. However, sa ganitong arrhythmia, your P waves are still present, the QRS complexes are still normal, and the PR interval are still normal. So kapag ganito ang tawag natin sa kanila, dahil meron pa rin siyang P wave, pero irregular yung R2R interval natin, we call it as sinus arrhythmia. So kapag sinus arrhythmia, iba yung process kung paano natin i-check yung ating rate. So kapag irregular yung rhythm ng ating ECG strip wherein iba-iba yung R2R interval natin, what we do is we compute for the heart rate using the 6-second rule. So the 6-second rule is we count 30 large boxes. So ibig sabihin 150 na small boxes yung bibilangin natin. And on that 30 large boxes, we count kung ilan yung QRS complex na meron doon. So just like for this ECG strip, meron tayong yan kinount ko na yan. So 30 big boxes yung meron dyan or 150 small boxes yung meron dyan. So the QRS complexes inside those 30 small boxes is ilan nga yan? 1, 2, 3, 4, 5, 6, 7, 8. So 8 times 10 is 80. So yung heart rate natin for this irregular rhythm is 80 beats per minute. So pasok pa rin naman siya dun sa normal heart rate natin. Yun nga lang irregular yung ating rhythm for this ECG. So we call this one as sinus arrhythmia. but yung rate natin is within normal limits pa rin. So yan. 8 times 10 is 80 beats per minute. Next, this is just also nice to know. So kadugtong lang siya nung una kong diniscuss kanina, yung intervals in our ECG. So for the P-wave duration, yung P-wave natin, dapat less than 3 small boxes siya para masabi natin na normal din yung duration ng P-wave natin. For your PR interval, suffice for you to know na less than 5 small boxes din siya para masabi natin na normal PR interval. And your QRS duration is less than 3 small boxes, and your QT interval is less than 11 small boxes. Okay? So far, are there any clarifications na you would like to ask before we proceed?
So far, wala naman po.
Okay, so sige, sir.
Naiintindihan natin why P-wave is important. Okay. Then I think Dr. Mariano will tell us why this interval or wave duration are important also. Kasi there are ECG findings which are dependent on these durations. Okay, let's see.
Okay, so yun lang. Sa isang ECG strip, talagang kailangan lang natin siyang tsagaing bilangin yung mga small boxes for us to determine talaga if merong abnormalities. So I hope you tinake note nyo na yung P-wave duration should be less than 3 small boxes. Your PR interval should be less than 5 small boxes. Your QRS duration should be less than 3 small boxes. And the QT interval, which is less than 11 small boxes. So within this, diniscuss ko sila na intervals. One of the most important intervals in this area is the QT interval. So there is what we call as QT prolongation. Kapag sobrang haba yung duration between your Q wave until sa end ng inyong T wave. So this is what we call as QT prolongation. One of the most important problems in your ECG. The causes of your QT prolongation includes medications, electrolyte imbalances like hypokalemia or hyperkalemia, hypomagnesemia, hypocalcemia, history of cardiac disease, and your congenital disorders. So if suspecting of a prolonged QT interval, pag kunwari nakita niyo parang ang haba ng QT interval, binilang niyo siya more than 11. So if you're suspecting prolonged QT interval, then QT should be computed and the causes should be determined in these patients. So your normal QT interval, as what I have discussed a while back, is 440 milliseconds to 450 milliseconds, or 0.44 seconds to 0.45 seconds. So in computing your QT interval, bibilangin lang ulit din natin yung small boxes from your Q wave until the end of your T wave. So kunwari, for this one, pag bibilangin mo yung small boxes na yan, that's 12. So 12 small boxes. So each small box, sabi nga natin kanina sa orientation ng ECG, is 0.04 seconds. So kung yung QT interval natin merong 12 small boxes, so 12 times 0.04, then that's 0.48 seconds or 480 milliseconds. Ibig sabihin, prolong yung QT interval natin. Okay? So yun siya. So ibig sabihin, meron tayong QT prolongation for these patients. So kapag nakita natin na merong prolonged QT yung patient, then kailangan nating ma-alarma. Kasi the QT prolongation complications are your torsade de pointes, ventricular fibrillation, and sudden cardiac death. So the rationale for knowing if the ECG has prolonged QT interval and to determine its causes is your QT prolongation event may be preceding event before a sudden cardiac death. So kapag nakita nyo na ang hahaba ng QT prolongation, kailangan natin ma-alarma. Okay? Because if we identify na merong QT prolongation yung patient na dumating sa atin sa ER, then we have to identify yung causes para ma-help natin yung possibility na magkaroon ng sudden cardiac death yung patient natin. So, patest kung sabihin ni Doc, mukhang prolong yung QT interval natin. That's when your doctor will tell you na, okay, sige, magpa-electrolytes tayo dito sa patient na to, or ano yung mga medications na iniinom niya. So, that would be a very big help to your physician kapag nasabi mo na, Doc, prolong yung QT interval niya. For this one of the most known medication causing your QT prolongation is your azithromycin. That's why minsan yung ibang physicians very responsible sila in giving your azithromycin, lalo na kapag alam nilang merong cardiac problem or merong arrhythmia yung mga patients nila, because your azithromycin can cause your QT prolongation. So preceding event ang QT prolongation for your torsade, ventricular fibrillation, and even sudden cardiac death. Okay? So next, nalaman na natin paano mag-compute ng rates, paano malaman kung sinus yung rhythm natin by determining the P waves. Next is your axis. So yung intervals, that's just nice to know, pero kung may time kayo to compute on the intervals, then we should do it. Next is determining the axis. So the orientation of the heart in your thorax is on the leftward side. Okay? And on the vertical axis, kung makikita nyo dito, upward is negative 90 degrees, and downward is your positive 90 degrees. And on your horizontal axis, 0 degrees, dito sa my left side, and 180 degrees on your right side. So medyo parang ang toxic nung slide, no, in determining the axis. So since, kunwari, yung mga ECG naman usually sa ER natin sa ginagawa, then tuturuan ko na lang kayo kung paano ma-determine yung axis ng heart natin in an easy way. Okay? So this is by eyeballing yung ituturo ko sa inyo. And during eyeballing of your axis, we look for the QRS deflections on your lead 1 and AVF. So if you can see dito sa ating table, dyan yung lead 1 sa first na column and lead AVF on your second column. So sabi niya, kapag normal ang axis ng heart, positive yung deflection sa lead 1 and positive yung deflection sa AVF. So that's upright QRS complex in your lead 1 and upright QRS complex on your AVF. So kapag nakita mo, upright yung QRS ni 1, upright yung QRS ni AVF, pwede mo na siyang i-call as normal axis. Kapag naman yung lead 1 natin is positive deflection but your AVF is negative deflection, or yung QRS mas mahaba yung downward deflection sa AVF, possible na left axis deviation siya. And kapag negative naman yung lead 1, instead of upright yung lead 1 mo, downward yung deflection ng QRS complex, pero yung AVF mo positive deflection, then that's right axis deviation. Okay, sige. I-drawing natin para mas maintindihan. So, kunwari, ay yung lead 1 natin, positive deflection siya. Tapos, positive deflection din yung AVF. Sorry, ang pangit ng drawing. So, positive, normal yung axis. So, lead 1 and lead AVF. Pero kapag positive yung deflection ng lead 1 natin and makita nyo kunwari yung AVF naman natin is pababa siya, then possible siya na left axis deviation. If negative naman yung ating lead 1, tapos yung ating AVF upright, so magkabaliktad siya, possible siya na right axis deviation. And kapag both of them are negative deflections, then that's extreme axis deviation. Diba, meron akong next na slide. Ayan. So makikita nyo, for normal axis, yung lead 1, paakyat, that should be AVF, hindi sa lead 2. Paakyat yung AVF. So lead 1 and AVF, upright deflection. For your normal axis, left axis deviation, ibig sabihin, yung heart nyo, nandyan naman siya, pag ganyan yung orientation, dyan sa part na yan, sa may negative 90 degrees to 0 degrees. So possible na left axis deviation siya. We call it as right axis deviation kapag yung lead 1 natin is downward deflection and your AVF is upward deflection. So this one. Doon sa between positive 180 hanggang positive 190 degrees to your positive 180 degrees. And 180 degrees to negative 90 degrees is your extreme right axis deviation. So yung orientation ng heart mo nandun sa may extreme right. So kapag kunwari dextrocardic yung mga patients natin, so nasa right axis, naka-deviate siya sa right yung heart natin. So makikita nyo, ganyan yung deflections ng inyong lead 1 and lead AVF. So that's the easiest way to determine your axis. Up, 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 down, down, up, and up, up. So kapag up, up, normal. Up, down, left axis deviation. Down, up, right axis deviation. And down, down is your extreme axis deviation. Okay? So that's just by eyeballing. Pag tingin mo lang nung strip na ganyan, nakita mo, up yung lead 1, up yung AVF. So this is normal axis. Pero pag nakita mo down yung lead 1, tapos down yung inyong AVF. So yan, up, up is normal axis. This is lead 1 and this is AVF. Up, down is your left axis deviation. Pag nag-down ang lead 1 at up ang AVF mo, that's your right axis deviation. Pero if both of them, your lead 1 and your AVF is downward, then that's extreme axis deviation. If marami ka namang time to compute for your axis, then meron tayong mas mahirap na computation, which is computing your frontal axis. So in computing your frontal axis, meron tayong formula dyan. So this is one of the best ways to determine your axis kasi mas objective. Yun kasing eyeballing, may mga times na kunwari up siya, pero if you compute for the axis, hindi, left axis deviation pala siya. If you compute talaga yung axis ng patient. Pero it would be suffice for you to know yung eyeballing na para at least masabi niyo agad dun sa physician ninyo yung axis ng ECG natin. So doing this computation of your frontal axis, we deduct the negative deflections from positive deflections in your QRS complexes to derive the values for your leads 1 and AVF. So kunwari, for this ECG strip, makikita nyo yung lead 1 merong 12 small boxes. So 12 yung gagamitin nating value for lead 1. Pero yung AVF, makita nyo kasi merong downward deflection. So Q, yung R is upward, then meron siyang S wave na 2 small boxes. So yung R wave ninyo is 10 boxes and your S wave is 2 small boxes. So i-deduct mo siya. So 10 minus 2 is 8. So the value for your lead 1 is 12 boxes and the value for your AVF is 8 boxes. Ayaw nyo na ma-erase. Okay, so etong part na to, sorry, yan yung bibilangin natin. So 12 small boxes siya, di ba? So that's the value for our lead 1. And eto naman sa AVF natin, eto, 10 siya, 10 small boxes. However, we have the S wave. Yung S wave natin merong 2 small boxes. So we have to subtract the negative deflection sa positive deflection natin for the AVF. So the value for this one is 8 and the value for lead 1 is 12. So what's constant here is your 90. So 90 times AVF, that's 90 times 8. And yung denominator natin is lead 1 plus lead AVF. So that's 12 plus 8. So 90 times 8 over your 12 plus 8, that's positive 36. So yan yung makakompute natin na value for our axis. So sabi niya, yung normal axis natin, the normal axis is negative 30 to positive 90, yung yellow na part. So that's the normal axis. So pasok siya kasi positive 36 yung na-compute natin. So within the normal limits ng axis natin. So ibig sabihin, nasa normal area yung heart natin. Hindi siya deviated. Okay? Next is, next are your chamber enlargement. So a review of your heart's anatomy. So This one is your right atrium, itong part na to. So dito nang gagaling yung SA node natin. So dito nag-uumpisa yung conduction ng ating puso. So that's the right atrium going to your right ventricle. So this is the right ventricle. This one is your tricuspid valve going to your pulmonic valve, and your left pulmonary arteries, then pupunta siya sa lungs, and then your left atrium, ito siya pupunta yung heart, then mitral valve going to your left ventricle, and then itatapon niya yung dugo papunta doon sa aorta natin. So this is the aorta and this is the aortic valve. Ang dumi na ng drawing. So yan, ganun lang yung flow. So kapag nag-fire si SA node, papunta sa ventricles, magko-contract naman si ventricles mo. Yun yung QRS complex natin. So, importante din na malaman natin kung enlarge yung right atrium natin or enlarge yung left atrium natin, malaki na ba yung ventricles natin. So yun yung next na ituturo ko sa inyo. Okay, first is your right atrial enlargement. So di ba kanina nakita natin, naturo ko sa inyo yung P wave. So for your right atrial enlargement, ang hahanapin natin ulit sa ECG ay yung P wave. So for patients with right atrial enlargement, you have your peaked P wave. Ibig sabihin, yung P wave ninyo is more than 2.5 mm amplitude. Ibig sabihin, yung taas ng inyong P wave or yung height ng P wave nyo is more than 2.5 small boxes. So, ita-check natin siya sa lead 2, pwede rin sa lead 3 or sa AVF. So, kapag makita natin na yung height ng ating P wave is more than 2.5 mm, then we can conclude na may possibility na merong right atrial enlargement yung patient natin. So, if you can see, dito sa ating screen, makita nyo na yung ating P wave is more than 2.5 mm. Kasi nasa 3 small boxes yung height ng ating P wave. So pag nakita nyo dun sa lead 2, parang ang taas ng P wave ninyo, then possible na right atrial enlargement siya. If we're talking naman about your left atrial enlargement, ang makikita naman natin sa kanya ay biphasic yung ating P wave. So ibig sabihin, meron siyang upright tapos may pababa ulit siya. Ayan, biphasic siya, P wave in V1 with a broad negative component. Ibig sabihin, mas malalim yung deflection ng ating P wave. So, nakikita niyo yung naka-encircle? Yan. So, akit siya, tapos bababa ulit siya. So, merong biphasic yung P wave natin sa V1. So, pwede natin siyang i-call as left atrial enlargement. Sa left atrial enlargement, may isa pa tayong criteria na pwede ring tignan para masabi natin na left atrial enlargement siya. Pag mukhang McDonald's yung ating P wave, ibig sabihin M-shaped or may notching yung ating P wave. Yan, no? Parang dalawang P wave. Para siyang McDonald's or letter M. Kapag yung P wave nyo para siyang letter M, then may possibility na may left atrial enlargement din yung patient natin. Okay? Yeah, actually we use a code. So for your right, laging tinuturo to ni Doc Kelvin sa amin. So right is height and your left is low deflection or biphasic. LL, low. So yun nga yung sabi ko kanina. Right is height, R. Pag mataas yung P wave ninyo, that's right atrial enlargement para hindi natin mapagbaliktad. And left atrial enlargement is left or low or may pababa na deflection sa ating P wave. Or yung biphasic P wave na tinuturo ko, or yung McDonald's. Okay? So yun yung clue natin. Right height, left low. Next, after nung dalawang atrium natin, may possibility din na hypertrophied yung ating right ventricle and left ventricle. So first is the right ventricular hypertrophy. So in your right ventricular hypertrophy, meron tayong criteria. So mas mahirap na siya kasi dapat kasama na yung mga diniscuss natin kanina prior to your right ventricular hypertrophy, like your axis deviation. So for us to know if your patient has right ventricular hypertrophy, first criteria is merong right axis deviation yung patient natin. So for this one, sige, tingnan nga natin by eye volume kung right axis deviation talaga siya. So in your lead 1, oops. Okay. Sa lead 1 natin, makikita natin yung downward deflection. Mas mahaba yung downward deflection natin than the upward deflection. And your AVF is upright. So sabi niya, up, up is normal axis. Up, down, left axis. Down, down, up is your right axis. So lead 1, down, tama. AVF, upright. So right axis deviation. So tama siya. So for this ECG, we have right axis deviation, check. Next criteria is dominant R wave in V1. So yung sa V1 natin, this one is your R wave. Yang mga yan. So dominant siya than your S wave. Mas matangkad si R wave than your S wave. So dominant yung R wave. So check ulit yung criteria na yan. Dominant S wave in V6. Ito. Mas malalim si S wave. So check na naman. And right ventricular strain pattern. Medyo technical na yung right ventricular strain patterns. But this one are your strain patterns. Yung mga yan. This one. Strain pattern, ibig sabihin parang nahihirapan yung right ventricle. So, para mas maintindihan, yung chest leads natin, yung V1 saka yung V2, di ba, nasa may right side siya ng heart. So, yung V1, V2, doon natin makikita. V3, nasa may right side yan ng heart. Makikita nyo parang hirap na hirap. Yung puso, yan o, meron siyang strain patterns. Yan. Instead na normal siya na aakyat, tapos ST, may S, tapos T, hindi, parang nahahatak pa siya pababa. Yan, parang pinupull yung ST segment natin. So merong strain patterns doon sa ating right ventricle. Kaya makikita natin yung strain pattern sa V1, V2, and V3 kasi yun yung nasa right side ng chest leads natin. Okay? Yun yung first 3 na chest leads na kinakabit natin. Doon yung makikita yung strain pattern. So kapag nakita niyo yung mga criteria na yan, right axis deviation, dominant yung R wave sa may V1, dominant yung S wave sa may V6, plus meron kayo nakikita na parang pinupull yung ST segment natin dyan, pwede niyo siyang sabihin na, Doc, mukhang may right ventricular hypertrophy yung patient natin. So pag sinabi niyo pa lang yun, mapapaisip na yung physician niyo, baka may ganitong sakit ng pasyente. Okay? So, very big help. Okay, next, kung merong right ventricular hypertrophy, meron din tayong left ventricular hypertrophy. Okay, so wait lang, before we proceed with left ventricular hypertrophy, nai-imagine nyo ba na yung right side ng heart, yung muscles ng right ventricle ay nahihirapan. So, mas mataas yung pressure ka merong strain, nasa strain siya. Okay, so
far gets ba natin? Balik mo na lang.
Or medyo na-overwhelm na.
Overwhelmed. So, to make it easier, imagine ninyo, yung right side of the heart, malaki. So, pag malaki yung right ventricle, dapat it follows din sa ECG if we want to, may right axis deviation. Kasi malaki na siya nagde-deviate na siya sa normal axis. Kaya kailangan may right axis deviation for you to tell it na may right ventricular hypertrophy. Okay? Imagine nyo rin na yung right is malaki na. So the blood supply, yung mga coronaries sa right ventricle, hindi niya na masupplyan yung kanyang muscles of the heart. Even the conduction system, malaki ay hindi na rin niya kayang supplyan. So nagkakaroon na siya ng strain pattern. Guys, nag-gets niyo o natutulog na kayo?
Gets mo
Nag-gets?
ba? Opo.
Okay. So,
Thank you,
yan,
Doc Calvin.
i-imagine nyo lang, no? Kasi yan lang naman ang kailangan sa RVH itong 4. Okay?
Thank you, Doc Calvin.
Mas mabilis ang LVH. Sige.
Yes. Medyo mahirap yung criteria kasi natin for the right ventricular hypertrophy. Kasi mas maraming patients ang merong left ventricular hypertrophy. Kasi ang madalas sa mga patients natin na hypertensive, ito yung pinakaunang naapektuhan yung left ventricles natin. So nag-hypertrophy sila dahil sa pressure. So in your left ventricular hypertrophy, we'll be using the ECS criteria, which is the Sokolov-Lyon criteria. So Sokolov-Lyon yung tawag natin sa criteria na to, which is i-check nyo lang yung S-wave sa V1 at yung R-wave either sa V5 or sa V6. So bibilangin nyo lang sa yung deflections. So kapag more than 35 millimeters or more than 35 small boxes, yung S-wave sa V1 plus R-wave sa V5 or sa V6, then pwede nyo na siyang equal as may left ventricular hypertrophy. So okay na yon, yung Sokolov-Lyon, kahit yun lang, no? So this is an example of an ECG with left ventricular hypertrophy. Okay? So bilangin natin. So sa V1, sabi niya, bibilangin natin yung S-wave sa V1. This one. Yan yung mga S-waves natin sa V1. So 5, 10, 15, 16, 17, 18. So that's around 18 to 19 small boxes. And sige, piliin na lang natin yung V6. So this is your R wave sa V6. So meron siyang almost 5, 10, 15, 20, 25. So 25. So 25 plus 19, that's 44 millimeters. That's more than 35 millimeters. So ibig sabihin, merong left ventricular hypertrophy na yung patient niyo. Yun lang. Yun lang yung bibilangin ninyo. And nice to know, di ba kanina tinuro namin ni Doc Kelvin yung right ventricular strain patterns. So yung V1, V2, V3, yun yung may parang hinahatak yung ST segment. Makikita nyo naman sa left ventricle, dun sa may left side ng chest leads natin, which is the V5 and V6, dyan nyo naman makikita yung parang hinahatak na ST. Okay? So meron din siyang left ventricular strain pattern. So yun lang yung mga titignan nyo dyan. Pero by computing yung S-wave at R-wave sa V1 and V6 and more than 35 siya, pwede nyo na siyang i-call na left ventricular hypertrophy. So hypertrophy, ibig sabihin, kumakapal yung cardiac muscles natin. So left ventricle naman ngayon yung kumakapal, no? So kung mas makapal yung left ventricle natin, ibig sabihin, yung position din ng heart natin, nasa left din. Going to the left din. So possibility, merong left axis deviation yung patient natin. Compared dun sa right axis deviation, meron namang mas makapal na yung right ventricle natin. So going towards the right naman yung ating position or yung axis ng heart natin. Sorry. Next is, so tapos na natin yung determining the rates, yung pagbibilang ng heart rate, determining the rhythm, kung sinus siya, kung regular or sinus arrhythmia, rate, rhythm, axis, tapos na natin yung axis, and yung enlargement or hypertrophy. So rate, rhythm, axis, hypertrophies. Ang next na lang na hanapin natin ay miscellaneous findings or abnormal findings sa ECG. And for us na nurses and physicians, one of the most important findings in our ECG is your myocardial infarction or ischemia. So di ba usually naman nagpapa-ECG tayo pag mukhang MI, mukhang may cardiac problem yung patient natin. So very important na malaman natin kung meron siyang MI yung patient natin. So looking at the screen, ischemia versus your infarction. So for your ischemia, blood flow is decreased lang. There is hypoxia or insufficient oxygenation, pero pwede pang mabuhay yung cardiac muscles natin. And if we say na infarction siya, na-cut off na yung blood flow dun sa area na yon, or na-block na yung coronary arteries natin. Therefore, magkakaroon ng necrosis or cellular death. doon sa cardiac muscle na sinusuplayan ng coronary artery kung saan may block siya. So doon, yun yung difference ng ischemia versus your infarction. And this photo lang, for normal blood flow, makikita nyo wala namang nakabara dyan. But for your, nakita nyo dyan, NSTEMI, sa non-ST elevation myocardial infarction na tinatawag nila, meron lang plaque buildup, so atherosclerosis, but meron pa rin blood flow sa area na yon. Pero dyan, may chance na mag-convert siya to total occlusion kapag merong thrombosis or may rupture ng plaque, pwedeng mabara yung ibang parts ng coronary arteries. And for STEMI, yung tinatawag natin na ST elevation myocardial infarction, there is total occlusion of your coronary arteries. So wala na talagang dadaloy na dugo. Kaya meron tayong myocardial infarction or meron tayong necrosis na dun sa area na yun. Okay? So if maalala nyo pa kung tinuturo sa inyo, kapag MI or angina yung pinag-uusapan natin, typically kapag angina, less than 20 minutes siya, lower tolerance for exertion, crescendo yung pattern niya, so pwede natin siyang i-call na angina. Pero be careful kasi meron tayong stable angina, yung mawawala din siya kapag nag-rest yung patient or less than 20 minutes lang din siya. Pero kapag, or less than 10 minutes, pero pag more than that, then we call it as unstable angina. Pero kapag dumating yung patient sa ER, masakit yung dibdib, pina-ECG, may nakita kayo, tapos nagpa-test siya, troponins, tapos elevated, then pwede na natin siyang i-call na acute coronary syndrome or your MI. So, depende rin siya kung NSTEMI or STEMI. So, yun yung ituturo ko naman mamaya. Okay? So, first, doon muna tayo sa NSTEMI or your non-ST elevation myocardial infarction. So, not all myocardial infarction will present with ST elevation na ECGs. Meron din tayong tinatawag na non-ST elevation myocardial infarction. So we have criteria in your ECG patterns in your non-ST elevation myocardial infarction. First, pwede tayong makakita ng ST segment depression or T-wave flattening or inversion or T-wave inversions. And sabi niya dyan, morphology of ST depression and T-wave inversion. There is horizontal or downsloping ST depression of more than 0.5 mm or half of the small box at the J point into contiguous leads. So hindi pwedeng isang lead lang yung may ST depression. Hindi siya, non-specific siya kapag ganun. Pero kapag two contiguous leads like V1, V2, meron kang ST depression or downsloping, V3, V4, V5, V6, or V1, V2, V3, V4, or V3, V4, V5, V6, 2, 3, AVF, mga contiguous leads, then pwede natin siyang i-call as significant na ST depressions. And for your ST depression, more than 1 mm or more than one small box naman will be more specific and will convey a more worse prognosis for our patients. And kapag nakita naman natin na T-wave inversions, mas sure tayo na MI siya kapag more than 3 millimeters or more than 3 small boxes yung T-wave inversions natin in contiguous leads. So as an example, this one, makikita nyo sa horizontal ST depression. So, yan, 1 mm halos yung binaba ng ating ST segment na dapat ay kapantay niya yung sa may area ng T-wave and downsloping, yan, parang strain pattern. Pero this is also ST depression. Okay? So for this one, itong ECG na to, highlight natin. For this ECG, may makikita kayong T-wave inversions sa may lead 1, sa may AVL, sa may V5, sa may V6. Yan. So meron tayong makikitang mga T-wave inversions dito sa ECG na to. So if this patient presents to you at the ER with chest pain more than 20 minutes, not relieved by rest, tapos in-ECG mo siya, meron kang nakitang T-wave inversion or ST depression in contiguous leads, then pwede mong sabihin na, Doc, mukhang MI na non-ST elevation. So kapag nasabi mo pa lang yun sa physician mo, plus yung characteristics ng chest pain niya, then makakapagbigay na siya agad ng initial management. Matutulungan natin agad yung patient natin. So if we would be able to identify these kinds of patterns sa ECG natin, on the spot, pagka-ECG natin ng patient natin with chest pain, sobrang laking tulong nun para mas maagapan natin na hindi mag-convert yung MI natin to total occlusion. So yun yung mga STEMI natin. Okay? Nagets ba for this part? Yung sa T-wave inversions and ST depression?
Yes, Doc. Apa, Doc.
Okay, clarify ko lang ha, laging 2 contiguous leads. Di bale mamaya ituturo ko naman kung saan yung mga contiguous leads. Kasi kunwari, yung lead 1 lang natin yung may T-wave inversion, then that's non-specific for MI. Kailangan laging may kasama siya ng mga T-wave inversions para malaman natin na doon sa area na yon, more than 2 contiguous leads dapat lagi yung mga T-wave inversion or yung ST depression natin. Next is STEMI or your ST elevation myocardial infarction. So in new ST elevation at the J point, in 2 contiguous leads of more than 1 millivolts lang daw in all leads other than V2 and V3. So kapag other than V2 and V3, meron tayong 0.1 millivolts or 1 mm na ST elevation in 2 contiguous leads, then pwede na natin siyang i-call as ST elevation. Pero for your leads V2 and V3, dapat more than 0.2 millivolts or more than 2 mm or more than 2 small boxes na ST elevation para masabi natin siya na STEMI. Okay? So yun. So, baka nalilito kayo yung sinasabi ko na J point. Ito siya. This is the J point. This is the J point. Diba? Supposedly, yung J point mo nandito. Pero yung kanya ilan? 1, 2, 3, 4. 4 mm yung inakyat ng J point natin. So, ST elevation siya kapag ganyan. Okay? Para siyang upuan, chair pattern na tinatawag natin. So, para siyang upuan. Ganyan. Chair pattern na ECG. So, yan. Kaya natin siya tinatawag na ST elevation myocardial infarction. So to further clarify things, ito yung sinasabi ko kanina na dapat contiguous leads. Sorry na late yung ating slide. Sa location naman siya. So ang magkakasama madalas is your V1 and V2, V3 and V4, your V5 and V6, your V1 to V4, V3 to V6, V1 to V6, extensive yung buong V1, V2, V3, V4, V5, V6. Merong STEMI or merong ST depression or T-wave inversion. Tinatawag naman natin inferior wall kapag ang magkakasamang leads ay your 2, lead 3, and your AVF. And we call it as high lateral pag ang magkasama ay 1 and AVL. So kapag kunwari, yung septum ng heart yung merong MI, yung muscle in between the ventricles, makakakita tayo ng T-wave inversion, ST depression, or ST elevation sa V1 and V2. So kung yung dalawang part lang na yun, V1 and V2 lang ang may ST elevation, then that's septal wall myocardial infarction. Kapag V3 and V4 naman ang magkasama, that's anterior wall. So the anterior part of the heart, dun yung myocardial infarction natin or dun yung may bara na sa coronary arteries. Kapag nagsama, ang V1, V2, V3, and V4, we call it as anteroseptal. So anterior wall and the septal wall, merong MI doon. And V3 to V6, kapag V3, V4, V5, V6 naman ang magkasama, yung anterior part ng heart and the lateral wall, meron siyang MI. So we call it as anterolateral wall MI. But if your V1 to V6, meron siyang ST depression, T-wave inversion, or ST elevation, V1 to V6, we call it as extensive anterior MI. So in this case, sabi nila, yung anterior wall, yung unang nagkakaroon ng myocardial infarction, then nag-extend siya to your lateral walls until your septal wall. So we call it as extensive anterior wall myocardial infarction. Yung tinatawag naman nilang inferior wall MI, makalalaman natin kapag ang merong significant STT wave changes ay lead 2 lead 3, and AVF. So ito yung chest limb leads and limb leads na tatlo ang magkakasama, comparing yung iba na 2 contiguous leads lang. Pero if we're considering inferior wall MI, dapat magkakasama yung lead 2, lead 3, and AVF para ma-call natin siya na inferior wall yung myocardial infarction natin. And di ba lateral wall, nakita nyo V5 and V6. Kapag 1 and AVL naman ang magkasama, we call it as high lateral wall myocardial infarction or dun sa upper part ng heart na upper lateral part ng heart natin. Pero kapag magkakasama naman, usually naman magkakasama na rin yan eh. 1 AVL, V5, and V6. So that's lateral wall na myocardial infarction. So buong lateral wall natin, merong MI. Okay? Take note nyo na yon. Meron tayong ginagamit na mnemonics, SAL. So septal, anterior, at saka lateral. SAL. So yung S is V1, V2. Anterior, your A is V3 and V4, and L is V5 and V6, SAL. So this is an ECG of an inferior wall myocardial infarction. So bakit siya inferior wall? Katulad ng sinabi ko kanina, kapag inferior wall, dapat magkakasama yung leads 2, leads 3, and AVF. So makakakita kayo ng chair pattern sa lead 2, lead 3, and AVF. So, contiguous lead siya, hindi lang lead 2. Kasi kung lead 2 lang yan, baka hindi naman siya MI. So, nakita natin, may chair pattern sa lead 2, sa lead 3, and AVF. So, kapag nakakita kayo ng ganyan, doc inferior wall STEMI, yung ECG findings natin sa patient. Siyempre, of course, dapat meron ding chest pain or merong angina yung patient natin. So minsan kahit na hindi na siya magpa-troponin ay kung makita na ST elevation tapos talagang Levine sign or may chest pain, may angina yung patient, pwede na natin i-manage rather than waiting for the laboratory result na troponin ay for 30 minutes to 1 hour. So very important yung time interval simula nung dumating yung patient sa ER hanggang mabigay natin yung yung medications natin. So that's ST elevation. Pero kasi the proper criteria to call it as myocardial infarction, dapat present yung tatlong criteria, which is your angina or your chest pain, laboratory findings of your troponin I na elevated plus ST elevation. So pwede yung sabihin sa physician na, Doc, may ST elevation dun sa 2, 3, and AVF or inferior wall. Para sabihin niya, okay, sige, magpa-troponin I ka na dyan sa patient na yan. Or pwede rin na magsabi niya, okay, sige, pwede niyo nang bigyan ng aspirin yung patient. Kasi kung makukall pa natin siya na talagang acute coronary syndrome siya, myocardial infarction, elevated yung troponin I natin, tapos may ST elevation na na-identify tayo, may angina yung patient, then meron pa tayo mas extensive na management na pwedeng gawin sa patient natin. Okay? The doctor will always call it as myocardial infarction. It will be suffice for you to say na, Doc, may ST elevation. Okay? Plus, merong chest pain yung patient natin more than 20 minutes. And then your doctor will say na kung ano pang next na gagawin natin sa kanya. Okay? Yes, sir, sorry. Aside from your troponin I, meron pa tayong isang ginagamit kapag hindi available yung troponin I, which is your CKMB. However, kasi for CKMB, pwede rin siyang elevated sa ibang problems, like kunwari may muscular problems yung patient natin, may infarction sa muscles, so pwede rin umakyat yung CKMB natin. Mas specific kasi si troponin I for your cardiac muscles. Pero if your troponin I's are not available, troponin I or troponin N, pwede tayong mag-request ng CKMB sa ating patients. Pero syempre, si doctor na rin ang magko-call nun kung anong i-request na laboratories for our patients. Ayun. And then, for your troponin I's and your CKMB, beware din, make sure na, kunwari, lalo na sa private na institutions, usually minsan walang resident, so yung nurse and the consultant lang. Make sure din na ma-history din natin yung patient natin ng mabuti. Kasi there are cases wherein elevated talaga yung troponin I natin. Like in patients with chronic kidney disease, very stable yung troponin I nila na elevated from the normal levels. Kapag may severe infection yung patient natin, nagkaroon ng hypotensive episodes yung patient natin, pwede ring mag-elevate yung mga markers na yan. Okay? So talagang in conjunction with your history, your physical examination, laboratory findings, and diagnostic workups yung pag-diagnose natin sa patient. Okay? Okay, so another example of your STEMI is this one. So nabilugan na siya, makikita nyo, meron tayong ST elevation sa V1, V2, V3, and V4. So, for contiguous leads, katulad ng sinabi ko kanina, SAL na mnemonics, SV1, V2, V3, and V4 is your A. So for this patient, meron siyang anteroseptal wall ST elevation. Okay, overwhelming na ba? Because we'll be moving na sa other abnormal ECG findings. So the most important ECG findings na pinakamalaman natin is yung ST elevation and ST depressions and T-wave inversions. Kasi madalas naman yung mga emergencies natin ay from MI.
So, ang dami mong participants, 115. Overwhelming. So, any question for Dr. Mariano or sa atin? From the group, meron ba sila, parang may questions sila. May question ata siya. Darwin Viernes, sabi niya, Doc, is PQRST only for pain?
What do you mean PQRST? Okay. So dun sa identification ng pain natin, like precipitating event, mga ganun ba? Quality of pain, radiation. Tama ba?
Yeah.
Yun ba yung question?
Daw. Ito yung nandito from Darwin Viernes.
Yes, of course. That's very important in our history taking, di ba? Kapag nag-complain ng chest pain yung patient. So kapag kahit anong pain pa yan, mapapaayan, chest, head, we have to qualify yung pain, yung PQRST. Ayun nga, ginagamit natin yan sa nursing. Actually, pati kami na residents, we use that one to qualify the pain. So yung quality ng pain, burning, basa, pricking yung pain niya, or chest heaviness, mga yan. So very important yan in our history taking and pag nakakita tayo ng patient presenting with chest pain. So kailangan mo ding i-qualify talaga yung pain. Kung gaano katagal, timing, during ba exertion or during at rest, nagkakaroon na siya ng pain. Very important findings yung mga yan. Okay, that would qualify for us physicians to diagnose our patients very well.
Thank you. Any more question? Pwede na kayong magtanong kasi mahirap hanapin si Dr. Mariano tsaka
Yes, before we proceed with the other abnormal ECG findings, baka meron tayong gustong i-clarify sa previous slides natin para naman ma-address natin as early as now. Kasi pag pumunta pa tayo sa other abnormal ECG findings, baka very overwhelming na for everyone.
Hello, Doc. Doc, may question po dito. Good morning, Doc. Ano po ibig sabihin pag non-specific STT wave change?
Okay. So we call it as non-specific STT wave changes kapag non-contiguous leads. Yun yung sinasabi ko kanina na dapat contiguous yung leads natin. Like V1, V2 dapat yung may ST depression. V3, V4, V5, V6. Laging dalawa, 2 to 3 na chest leads or limb leads. Kasi kunwari, ECG findings mo, normal, pero bigla kang may nakita sa V3, may ST depression. So that's non-contiguous kasi nasa V3 lang siya. Wala siyang kasamang V4 or V2, V3, V4, V5 kung sakali. So nasa iisang lead lang siya. So that's non-specific for possible MI sa patient natin. Pwede lang din siyang artifact or pwedeng meron lang tayong electrolyte abnormalities and hindi talaga siya myocardial infarction. Even the flattening of your T waves, madalas makakita nyo, ay, ba't wala siyang T wave? Eh, sabi ni Dr. Mariano, kapag may flattening ng T wave, pwede siyang non-ST na myocardial infarction. Even your T wave flattening can be non-specific, lalo na kung non-contiguous yung leads. O kaya, pwede rin nating sabihin na non-specific ST wave changes kapag wala namang chest pain yung patient. Sabihin natin, 25 years old, pina-ECG, walang chest pain, pero nakita mo may T-wave inversion. So that's not MI, lalo na kung nasa iisang lead lang siya. So kapag sinign out siya doon sa ECG result, makikita mo, or doon sa official ECG reading, doon kayo nakakita na non-specific ST wave changes. Ganun.
Thank you, Doc. Doc, question po, ano po yung initial management natin for a patient with MI?
Okay, I think kasi as nurses, di ba, usually we wait for the physician's management bago tayo magbigay ng medication sa patient natin. Kasi if sometimes baka mamaya may makita pa si doctor na other findings sa patient na to na pwede niyang differential, baka naman hindi siya MI. Baka detrimental din kasi sa patient natin if, uy, STEMI, bigyan ko na siya ng aspirin, clopidogrel. Mag-load na tayo ng 4 tabs ng aspirin kasi mukha namang MI. Pero if, kunwari, for us physicians, nakita namin na mukhang MI nga yung patient, may ST depression or ST elevation, merong qualifier na angina na not relieved by rest, plus kunwari mabilis naman yung troponin I natin, then naglo-load na kami ng aspirin, ng clopidogrel, nagbibigay na kami ng low molecular weight heparin. Okay? Kasi meron pa kaming other management, like kunwari, kung sa time frame namin pasok siya, pwede kaming mag-thrombolize. Thrombolysis tawag natin if we can give heparin, pwedeng heparin ang gamitin natin, or pwede rin streptokinase. So dito, sa SIMC, we do thrombolysis kapag nakakatch namin yung patients natin with STEMI. So makikita namin during the thrombolysis yung STEMI, every 15 minutes nag-ECG kami dyan while ongoing yung drip namin ng streptokinase. After 1 hour nung drip, mamaya normal na yung ECG niya. Ibig sabihin, natunaw na namin yung bara dun sa coronary artery ng patient. Pero it would be suffice for us or for you guys na makita na merong na merong abnormality sa ECG like ST elevation, T-wave inversion, T-wave flattening, yung mga yan, or QT prolongation, mga yan.
Yes, I agree with Dr. Mariano kasi nowadays kasi we have the tendency to be reactive, no? Nasa rural area tayo, barangay, na ECG, nakita nyo, ay, ang galing ni Dr. Mariano kasi sobrang ganda ng ECG, ganyan. Naintindihan mo talaga yung ECG. But the problem is, baka maging reactive tayo sa lugar na yon at kaliwat kanan, bigay ka na ng ganito, bigay ka na ng ganito. So, iisipin mo na, baka okay na yung binigay ko. Yun doon kasi yung urgency na dapat kapag may ECG findings, lalo na't may symptoms, dapat idala sa ospital. Kasi there's a golden period for us, yung 6 hours para makita natin agad yung pasyente. Baka mabigyan nyo ng, sige, bigyan natin ng aspirin, pa-tune natin yung aspirin, then bigyan natin clopidogrel, tapos madidelay na yung management, tapos ma-salvageable pa kasi yung first 6 hours ng heart. So, kailangan diretso agad sa ospital. Huwag tayo magbibigay ng emergency na gamot. Lalo na yung complacency. Baka nandun yung complacency, hindi tumakbo sa ospital. Since nabigyan naman na ako ng nurse. In my private practice, ganun with high regards pa rin ng mga patient natin with you nurses. So, be careful on giving medications. Just to add up then, other drugs na commonly used in our society na nagkukos ng QT interval is domperidone. So we don't give domperidone sa elderly patients because they are prone to have prolongation of QT. So hindi tayo dapat magma-manage on our own. Okay? Kung kailangan dalhin sa ospital, ospital talaga. Thank you.
Thank you, Doc Calvin.
From
Thank you,
Dr. Tamayo po. Thank you po, Doc Mariano, for a very easy to understand and simple delivery on normally a very hard to understand topic. Thank you also to Dr. Calvin ko from Dr. Lilian Tamayo po.
Thank you, Dr.
Thank you, Doc.
Okay, if there are no more questions, siguro we can fast track na yung other abnormal ECG findings. Okay, thank you, Doc. Okay, sige. So sinama ko pa rin dun sa abnormal ECG findings yung sinus tachycardia. So this is very easy. Normal yung ECG natin, but then yung rate natin is more than 100. So kapag more than 100, merong P wave, sinus, so we call it as sinus tachycardia. So for this patient, makikita nyo na yung R to R interval natin, ilan? Yung small boxes. So for this one is 9. So 1,500 divided by 9, that's 166. So yung heart rate ng patient natin na to is 166. However, looking at the ECG, normal naman lahat, meron kang P wave, normal yung axis mo, wala kang ST elevation, wala kang ST depression, then sinus tachycardia lang yung ganitong ECG. Okay? So tachy lang yung pasyente natin. Next is this one, sinus bradycardia. So, sobrang bagal ng heart rate natin. Counting the small boxes between your R2R intervals, that's 40 small boxes. So again, 1,500 divided by 40, yung heart rate ng patient natin na to ay nasa 38 beats per minute lang. So it's less than 60 beats per minute. So it's sinus bradycardia. Meron pa rin naman tayong T wave. Okay? Next, siguro madalas nakakakita kayo nito or madalas naririnig nyo yung resident physician ninyo na SVT yung pasyente. So it's a supraventricular tachycardia. So the features for your SVT includes a narrow complex QRS complexes. So di ba sabi kanina yung QRS complex dapat less than 0.12. So mas narrow pa dun yung mga patients na to. Kasi tachycardic na siya, nasa 140 to 220 beats per minute yung heart rate natin. Tapos wala kami makikitang P-wave. Parang ang makikita nyo lang dyan ay QRS complexes and yung P-wave nyo na mukhang ang taas kasi sobrang bilis ng heart rate. So for this one, it's called supraventricular tachycardia. Okay? So 140 to 220, tas wala kang makitang P-wave, tachycardic, your patient presents with nahihirapang huminga, anxious siya, meron siyang palpitations. So, pwede siyang SVT. Minsan, yun lang kasi others will be having a hard time to identify your supraventricular tachycardia and your sinus tachycardia. So, sinus tachycardia kasi makikita mo pa yung P-waves natin eh. Pero in your SVT, minsan, hindi na talaga natin makikita yung P-waves natin. Nakabaon na siya doon sa QRS complexes natin sa sobrang bilis niya. So this one is SVT. So the provoking factors for your SVT will include exertion, caffeine. So kapag yung patient mo, sabi niya, napakapi po ako ng 5 baso ngayong araw. Tapos after that, nagpalpitate siya pagkakita man ng ECG niya ganito. SVT siguro to. Kasi uminom ng maraming kape yung patient. Alcohol, pwede rin. Your beta-2 agonist or your salbutamol nebulizations can cause your SVT. And of course, your sympathomimetics or your amphetamines, pwede rin siya. Okay, so your SVT, mas common siya sa females than the males. Pwedeng magkaroon ng syncope yung patient kapag nag-SVT sila, so pwede silang himatay. Okay? Next, siguro minsan naririnig nyo, ano kayong tinatawag nila, Doc, na atrial fibrillation? So, atrial fibrillation is the most common sustained arrhythmia. It is characterized by your disorganized atrial electrical activity and contraction. So, wala kang nakikitang P-wave. dito. So yung features ng atrial fibrillation natin is, sabi niya, ito lang yung dalawang tatandaan nyo, irregular rhythm and no P waves. So makikita nyo, iba-iba yung R2R interval natin. Di ba? Magkakaiba siya. May mas mahaba, may mas maiksi na R2R interval. Pero pag tingin mo dun sa ating ECG, wala kang mahanap na P wave. Or minsan, parang ang daming P wave. Parang, no, kaya itong mga to, T or P, parang sobrang dami nila, very erratic. That's when we sign out the ECG as atrial fibrillation. Okay? So very important na ma-identify nyo siya kapag AF. Dok, mukhang AF, wala pong P wave, tapos irregular yung QRS complexes natin. Okay? Para makapagbigay ulit ng initial management yung physicians natin.
Siya nung i-indicate
Yes,
mo,
Doc, sorry po.
indicate mo din na sa PE, possible din natin ma-detect ang atrial fibrillation.
Yes. Sa
Pulse rate.
actually, yes, Doc. Bago natin makita yung ECG, kapag merong atrial fibrillation ng patient, pwede ka na mag-suspect na may AF yung patient. Kapag in-auscultate mo siya, very irregular yung rhythm. Imbes na labdab na regular, minsan iba-iba, like bibilis, o kaya babagal yung heart rate niya. Tapos may mga parang skip beats na tinatawag natin. Baka AF na itong patient. So even sa pulse, mararamdaman mo siya na very irregular yung rhythm instead of the very constant na rhythm ng heart natin. Tapos pagka-ECG mo sa kanya, makikita mo very irregular yung R2R, tapos wala kang P-wave, atrial fibrillation yung ating ECG.
Tsaka maano mo siya sa pag in-auscultate mo yung heart, hindi siya congruent with the pulse rate. So magsa-suspect ka talaga.
Atrial fibrillation. Thank you, Doc. Next abnormal ECG waveform is your ventricular tachycardia. So, ayan, very easy na yan kapag nakakita kayo ng ganyan. VTAC. Oh, may VTAC yung patient. So, the features of your ventricular tachycardia are regular, broad na complex, QRS complexes, and very uniform yung QRS natin. So, QRS yung mga yan. So all of this one are QRS complexes na very broad. More than 0.12 siya. So kapag nakita nyo ganyan, pare-parehas sa lahat ng leads, VTAC yan. Most common, monomorphic VTAC, tawag natin. Kasi may dalawang klase ng VTAC, yung polymorphic at monomorphic. Monomorphic, ibig sabihin, magkakaitsura lahat yung QRS complexes mo. So very uniform siya, hindi siya irregular. Regular yan, na QRS complex na very broad. Tapos ganyan lang yung makikita nyo, wala kang makikitang P-wave, wala kang makikitang T-wave. So ventricular tachycardia. Sa VTAC, hindi lang lahat ng nag-VTAC wala nang malay or parang nag-arrest tas nag-VTAC. Pero pwede rin natin makita ang VTAC kahit gising yung pasyente. So we can see VTAC in stable patients, may BP, may cardiac rate, pwede silang mag-VTAC. Pero karamihan ng nakikita natin na VTAC, madalas wala silang BP, walang pulse, o kaya post-arrest yung patient natin. So they can go into VTAC. Next is another feature of VTAC, which is the polymorphic ventricular tachycardia. So this is a form of your ventricular tachycardia na irregular yung QRS complexes natin. This is what we call as torsade de Pointes. Okay, torsade de Pointes siya, hindi siya torsade de Pontois. Okay? So that's the abbreviation is TDP or your torsade. So this is a specific form of your ventricular tachycardia occurring after QT prolongation. So yung preceding event for these kinds of patients are your QT prolongation, yung diniscuss ko kanina. So kapag na-identify nyo merong QT prolongation yung patient, tapos bigla siyang nag-VTAC, madalas makakakita kayo ng ganito, polymorphic or your torsade. Torsade, parang siyang nag-twist, parang umiikot yung ECG waveforms. Makikita nyo may mga mas maliliit, tapos lalaki ulit siya, tapos liliit, tapos lalaki siya. Okay? Polymorphic VTAC ang tawag sa. Yung iba nalilito between your ventricular tachycardia and ventricular fibrillation. For your ventricular fibrillation, mas maliliit siya yung complexes compared to your VTAC. Sa VTAC kasi regular, tapos very tall na QRS complexes pa rin siya. Pero for your ventricular fibrillation, maliliit siya na irregular na broad na patterns. So your ventricular fibrillation is the most important shockable cardiac arrest rhythm. And it is invariably fatal. Pwedeng gising din yung pasyente, pero pag naagapan mo at na-identify mo siya na ventricular fibrillation, pwede nating ma-revive agad yung patient natin. So this one, meron tayong makikita na chaotic irregular deflections of varying amplitudes. Iba-iba yung amplitude ng ng complexes natin. And of course, no identifiable P waves, no identifiable QRS complexes, walang P waves, and the rate for ventricular fibrillation is nasa 150 to 500 per minute. Okay, so nagfibrillate na lang yung heart. So wala tayong cardiac output, walang dugo na dumadaloy sa coronary arteries natin. So kapag hindi natin na-halt yung ventricular fibrillation, then pwedeng mag-arrest agad yung patient natin. Okay? Okay, so yun yung mga most important abnormal ECG findings na sinama ko sa lecture na to. Your ventricular fibrillation, yung ventricular tachycardia, atrial fibrillation, your SVT, and of course, your sinus bradycardia and sinus tachycardia. So, yun, before we go to the practice ECGs, are there any questions with regards dun sa abnormal ECGs na diniscuss natin? Or na-overwhelm na ulit?
So, gawin mo na lang pa-contest yung yung practice ECG. Pa-Gcash tayo.
Si Sir Enriquez ang magbibigay ng prize.
Pa-contest.
Okay,
May
sige.
question po dito.
If wala nang... Ay, sige po.
How about daw po yung mga energy drinks like Cobra, Sting? Nagkakos rin po ba yun?
Yes, pwede silang mag-cause actually ng supraventricular tachycardia, yung mga yun. Caffeinated pa rin yung mga yun eh. Plus merong mga ibang chemicals which may cause your supraventricular tachycardia.
Yes, particularly
Pwede silang mag-palpitate.
ER people, nakikita nyo na to every morning because energy drinks are filled with high dose ng sugar and caffeine. So, ang particular symptoms is palpitation. Worst is arrest. Okay? So, hindi rin maganda talagang energy drink.
Yes. Thank you, Doc. The physiology for that, yung sinabi ni Dr. Kelvin na pwede sila mag-arrest kapag nag-tachycardia kasi tayo, ibig sabihin hindi adequate yung pag-contract ng heart natin kasi sobrang bilis siya. So hindi napapump out yung blood from your ventricles going to your coronary arteries and going all over your body. So ibig sabihin kapag hindi nag-contract ng mabuti yung ventricles natin, hindi niya masusuplayan yung coronary arteries. So hindi rin siya nagre-relax. So pwede kang mag-arrest. Kahit pabata ka. Kapag nag-SVT ka na tuloy-tuloy, hindi na control. Yeah. Are there any questions? Siguro, Sir Enriquez, if ever kung nahihiya pa silang magtanong, then you can compile siguro yung questions. And you can send it to me naman and then I can answer pa rin yung questions. Tapos pwedeng ibigay sa kanila if ever.
May isa pa po dito sa ating chat box.
Yes po. Sige
Tanong
po.
lang po kung ano po possible cause of sinus arrhythmia and possible medical management po.
Okay. Depende kasi sa sinus arrhythmia, pwedeng minsan makakita tayo ng sinus arrhythmia based sa age. So sa elderly, minsan irregular na talaga yung heart rate nila. Pero the most common causes pa rin of your sinus arrhythmia is electrolyte imbalances, because your electrolytes control your the contraction of the heart, specifically your calcium, your potassium. So those are very important electrolytes in the conduction system of our heart. Yeah.
Thank you, Doc.
Medications can also cause your arrhythmia.
Doc, may tanong pa si Sir Jello. How old are you, Doc?
Irrelevant.
Bata pa.
Oo. Baka napapansin nga, no, hindi kami nagbibigay ng management, especially when it comes to the cure. Kasi maraming pwedeng complication complication kasi once na binigay natin yung ganong management. So, maybe meron din kayong nakikita na alam ko naman sa BLS, di ba, yung nagka-carotid rub. So we seldom do that, especially sa elderly. No, kasi baka meron. Dr. Mariano, explain.
Yes, sorry. Yan, tama si Dr. Kelvin. Kaya siguro napansin nyo kanina nung dinidiscuss ko yung SVT, hindi ko sinabi na pwede kayong mag-carotid massage because depende sa physical examination madalas ng physician kung anong gagawin niyang management. Kasi kunwari elderly, nagsususpect siya, merong brewy. Ibig sabihin, merong parang stenosis doon sa may carotid arteries natin pag inoscultate niya. So most likely, merong atherosclerosis sa area na yon. And it's a no-no for us to do carotid massage kasi pwedeng mag-dislodge yung mga thrombus doon, yung mga plaques natin. So kapag minassage mo yung carotid arteries ng isang matanda, na-dislodge mo yung plaque doon, babara siya sa utak ng patient natin. So mag-induce pa tayo ng further harm sa patient natin kasi mag-stroke siya.
Yes.
Kaya very crucial ang management. Kaya I think it's still best for us to update our physicians and antayin natin yung ibibigay nilang management rather than yung reactive nga tayo na sabi ni Dr. Kelvin.
And don't be reactive also pag naka-receive kayo ng kamag-anak nyo na ECG, sinus, arrhythmia. Commonly, it's benign unless it's new onset. More questions?
Sa Viagra, possible po ba magka-SVT?
Sa Viagra, I'm not so sure with Viagra, pero your Viagra kasi are your phosphodiesterase inhibitors. They can cause vasodilation. So kapag vasodilation, mas madalas brady ang effect nito rather than tachycardia.
Thank you, Doc.
And hypotension, of course. Not really sa rhythm. Sa hypotension siya. Kasi vasodilator siya.
Yes. And be careful on giving your relatives or friends na nangihingi ng Viagra because it's true it can cause arrest also. So, kailangan talagang kiniklear sila ng cardio or ng internist prior to intake of it.
Sildenafil.
Dr. Shanong, ano yung activity?
Yes, Doc.
Ano yung activity mo? Baka
okay.
we can make it
Proceed na, Doc.
more fun.
Okay, sige, Doc. Ano na lang, for us to know, for us to know kung nakinig talaga sila. Yes, Doc. I'll be showing ECG strips.
Sige, magpapa-Gcash tayo ng yung unang sasagot, no? Yung unang appear dito sa group chat na sagot. Okay?
Okay,
so,
sige. Sige, Doc.
Magkano ang Gcash natin? Sige. Pwede na siguro yung 200. May milk dito. Sige,
okay, so yun. Nag-prepare ako ng 5 ECG strips. So, I will be flashing on the screen an ECG strip. Tapos, yung first to answer kung kahit kung ano yung findings mo dun sa ECG na yon, then siya yung mananalo ng Gcash from Dr. Kelvin. Okay, so first na magchat-chat ba, Doc?
First to
Yes.
answer correctly.
Okay, first to answer correctly. Baka naman mamaya mali pala yung sagot niya.
Sige, taas na natin.
Okay.
300.
Okay, sige. First to answer, our first ECG strip is this one. Super dali lang yan. Okay, pinakauna si Ma'am Rochelle May Valdez. Ay, tama ba?
Wait. Sino bang admin?
Angge po.
Si Ma'am Angge.
Yes. Sino si Ma'am Angge? From what hospital?
SMC po, Doc. From ER.
Ay, pa-note na lang. Bigay ko na lang, i-Gcash ko na lang sa'yo.
Sige po, sige po.
Okay, Ma'am Angge, congratulations. Yes, you are right. This is normal sinus rhythm ECG. So checking the standardization, sinabi ko kanina, the speed is 25 millimeters per second and the height is 10 millimeters per millivolts. This is sinus, 75 beats per minute, 20 small boxes, no normal axis, no hypertrophies, and no noted ischemic changes. So this can be signed out as normal sinus rhythm. Congratulations, Ma'am Angge. Okay, next. 300 pa rin ba, Doc Kelvin? Okay. Next, ECG strip. Super easy lang din yan.
Sino kaya dito?
Disqualified na ba si Ma'am Angge?
Oo, nanalo na.
Nanalo na siya. Okay, so kung disqualified si Ma'am Angge, the next one is Ma'am Shemaya Flores. From what hospital si Ma'am Shemaya?
SMC po, ICU.
SMC din. ICU. Okay, so tama si Ma'am Shemaya. This is sinus tachycardia. So the rate for this one is 136 beats per minute because we have 11 small boxes between your R2R intervals. And normal axis, no hypertrophies, and no noted ischemic changes. So sinus tachycardia lang siya. Okay? Congratulations, Ma'am Shemaya. Next, super easy lang din tong susunod.
Chano?
Yes, Doc?
Para ma-clarify lang din si Vanessa na VTAC ba ang gusto niyang sabihin dito? Ventricular tachy. Para maano lang sa photographic memory niya, i-flash mo yung VTAC.
Sorry, wait lang. VTAC. Okay, balik tayo dun sa VTAC kanina.
Tsaka may sumagot kasi ng AFib doon sa normal sinus natin.
Okay, sorry, Doc. So, ito yung VTAC natin, no? Wala kang makikitang P-wave, wala kang makikitang T-wave, although uniform yung QRS complexes natin. Pero halos puro ganyan lang yung makikita mo. Dito kasi sa ECG natin, yung flash ko na ECG is, ayan, meron kang P-wave. Sana siya? Ayan, may mga P-wave ka pa rin, di ba, sa lead 2. Yan, may P-wave, sa long lead 2, yan, may P-wave, followed by your QRS complex and your T-wave. Sa VTAC, irregular siya na puro ganyan lang, upright. So hindi siya, VTAC, sinus tachycardia lang siya. Masyado lang mabilis yung heart rate natin. And then, Doc, yung first one kanina, tama ba? May sumagot ng AFib?
Yes. Baka kasi
so this one,
yung grounded kasi yung ECG.
Yes. I'm so sorry. Medyo grounded nga siya. Pero the first thing you should check is the P-wave, di ba? To check kung sinus siya. Kasi sa atrial fibrillation, hindi sa sinus kasi wala kang ma-identify na P-waves. But for this one, checking at the long lead 2, makikita mo meron kang P-wave. Nakikita ba yung arrow?
Yes.
Ayan, sorry, Doc. Yan, so may P wave, another P wave, P wave, P wave, followed by your QRS complexes, QRS complexes. And kung i-caliper nyo to, pantay-pantay sa yung R2R interval. Yeah, pantay-pantay yan. Sa AF kasi hindi yan pantay-pantay yung R2R interval. So mas may mahaba, may mas maiksi na R2R interval. Okay? So doon yung sa masasabi na atrial fibrillation siya.
And
Okay?
commonly, ang atrial flutter, kasi di ba AFib and atrial flutter, ang atrial flutter is may sawtooth. So baka doon nyo na-correlate na baka yung grounded is sawtooth. Meron kang picture ng
Yes. Sorry, Doc, hindi ako naglagay ng atrial flutter. Pero yes, dapat pala naglagay tayo ng atrial flutter to identify between flutter and fibrillation.
Yung sawtooth is yung lagare. Ganon mismo yung ngipin niya. Okay? So, para hindi kayo maguluhan. Okay lang na magtanong. Okay lang na magkaroon tayo ng clarification.
Yung sa flutter natin, usually ganito yung itsura.
Yes.
Parang ganyan. Yan, atrial flutter yung ganyan.
Okay, next.
Okay? Yes, thank you, Doc. Next, ECG strip. Ayan, madali lang.
Open din itong contest natin sa ibang ospital, ha? Open din sa ibang hospital, hindi sa SMC. Go.
Okay, correct answer, ha? Including yung affected na area ng puso. Yung mga nag-notes, makukuha ng tama. Okay, wala pang nakakakuha. Wala pa. Okay, Ma'am Rochelle May Valdez. Hello?
Ma'am Rochelle, pa-open.
Hello?
Pa-open ng ano.
Okay, so I'm not so sure kung si Ma'am Rochelle yung pinaka-naunang sumagot ng anteroseptal wall myocardial infarction.
Check
Siya
natin.
ba? Extensive, SVT,
The
STEMI.
anterior ischemic. Ay, wait. Sinus.
Mukhang siya, Doc, yung pinakauna.
Meron dito si lateral wall, SVT. Si Astrid, mas nauna ba siya kay Astrid?
Doc,
Ay,
anterior lang kasi yung, yes, Doc, anterior
Yes.
lang yung nalagay niya.
Si
Yes.
Rochelle.
So
Ma'am
the first one to send a correct answer is Ma'am Rochelle May Valdez. So she is right. This is anteroseptal wall myocardial infarction. So looking at the ECG,
Let her
Doc?
explain. Let her explain.
okay, sige. Hello,
Ma'am
Ma'am Rochelle.
Hello, good morning, Doc.
So
Good
bakit
morning.
Yung sa may ano kasi, Doc, V1 and V2 is septal wall. Meron siyang chair-like or yung chair or chair-like na parang drawing yung elevated na SC segment niya. V1, V2, V3, and V4 po.
Mm-hmm.
Yun po, Doc.
Oh.
Doon ko siya nakita
Okay.
ng SC na may chair-like na pattern.
Ano nakikita mo sa V5, V6?
Ano siya, Doc? Parang ano siya, Doc, yung ST niya is nasa, ano tawag doon? yung parang iso line, hindi siya elevated, Doc, kasi yung ST niya. Isometric line ba yung tawag doon?
Sa B5, B6.
Hindi ba siya mas mababa than the isoelectric point?
Mas maano siya, Doc. Yung sa B5, Doc, yung ST niya, medyo mababa lang siya. Yung start ng ST niya, Doc, mas mababa sa isoelectric line. Pero yung T niya, Doc, nasa isoelectric line. Pati yung B6 naman, Doc, mas mataas siya. Pero wala po kasi yung ating, hindi siya mas mataas dun sa, ano tawag dun, yung sa may, sa millivolts ba yung tawag dun? Yung Doc. Yung size boxes.
Okay, sige.
Ganun
So
po.
yung nakikita niyo dyan, ay tama. Tama si Ma'am Rochelle, no?
Yes, Doc.
Tama siya na this is an anteroseptal wall na myocardial infarction. Yung tinatanong ni Doc Kelvin sa kanya sa B5 and B6 are ST depressions. So, ito yung tinatawag natin na reciprocal changes sa ECG findings natin. So, dahil merong infarction dun sa anteroseptal wall, meron naman tayong ST T-wave changes dun sa may lateral wall. So, yun yung reciprocal change. So, mas ma-clinch natin yung diagnosis na MI nga ito, na anteroseptal wall. So, congratulations, Ma'am Rochelle. Yung iba, ang mga sagot ay anterior. So, meron pa kasi tayong ST elevation sa V1 and V2, kaya dapat anteroseptal siya. Inferior wall MI, sabi ni Sir Albert, siguro dahil mukhang may ST depression dun sa 2-3 AVF. Pero what's striking in this ECG are your chair-like patterns or ST elevation in your leads V1 to V4. Kaya ST elevation, myocardial infarction siya na anteroseptal wall. Okay? Congratulations, Ma'am Rochelle. Okay? Going to our second to the last ECG strip. Ayan, medyo mahirap. Pero diniscuss ko to kanina.
Wala pang sumasagot.
Wala pa? Yung nag-take down ng notes niya dun sa contiguous leads, makukuha niya to.
Nagbigay ka pa ng clue.
Wala pang tama.
Sa video po ko eh. Video. Video ka?
Pupunta siya ng BDO. We find ways.
Wala pa? Okay, magbigay tayo ng clue. Sige, MI din ito, na non-ST. And STEMI siya. Pero, anong wall siya ng heart? Yun na lang. Anong wall? Sige, ano na lang. Other qualifiers for this patient para mas hindi kayo malito. So, may dumating, 60-year-old na male na smoker, may history ng hypertension, na more than 30 minutes na siyang nagkakaroon ng chest pain, kahit mag-rest siya, hindi na-relieve. Tapos, nagpagawa agad ng troponin I elevated, tapos nag-ECG ka, ganito yung makikita mo.
Makita.
Sulit yung 300 dito.
Mamimili lang kayo doon sa diniscuss ko na mga walls. Okay. Mabilisan. Ayan, oo. Balik ko na. Ano ba? Kasama ba si Sir Enriquez?
Si Ike.
Isasama ba natin, Doc, si Sir Enriquez dun sa laro?
Pwede naman. Wala naman siyang clue eh. Ay, wala
Okay,
naman.
sige. Pero Sir Ike got the correct answer. So this one is an extensive anterior wall myocardial infarction. So yung flash ko kanina, if meron kang almost diffuse na T-wave inversions or ST depression, sa chest leads, then we can call it as extensive anterior wall myocardial infarction. So kung makikita nyo, although flattening lang kasi yung V1, and then sa V2, T-wave inversion, pero the deepest T-wave inversions are seen in your V3 and V4, which coincides with your anterior wall, and then nag-extend siya until your lateral wall, pati sa septal. So kapag ganito kasi, when your anterior myocardial infarction extends to the septal and lateral regions as well, the culprit lesion is usually more of the proximal or your left as anterior descending coronary artery kapag ganito. Pero we can call it as extensive anterior wall myocardial infarction. Sorry, very technical siya. Pero yun, the correct answer is extensive anterior wall myocardial infarction. So tama si Sir Ike.
Thank you, Doc.
Okay, congratulations, sir.
Hindi pala dapat siya kasama.
Okay, so sa last na ECG strip natin, sa huling 300 pesos from Dr. Kelvin. Ayan. Madali na lang yan. Okay, congratulations, Sir Albert. So this one is atrial fibrillation. Kasi wala kang makikitang P waves, tapos irregular yung R2R intervals. Sa lahat ng leads. Limb leads and your chest leads, irregular yung R2R interval natin. Irregular with no noted P waves. So this one is atrial fibrillation. So congratulations, Sir Albert. So hindi siya SVT kasi irregular yung ating R2R intervals. Pero kapag yan, regular ang R2R interval at wala ka nang makitang P-wave, then we can call it as supraventricular tachycardia. However, for this one, irregular yung R2R interval natin.
And
okay, so congrats.
Congratulations. Since naka-identify kayo ng AF, may mga qualifiers pa rin ng AF. Shanong.
Ay, yes, Doc. Sorry, Doc. So for your EF, yung mga qualifiers natin ay meron dapat siyang feeling of palpitations, mga yan, or dapat meron tayong causes, or dati na siyang merong atrial fibrillation. So minsan kasi alam na nila na irregular yung heart rate nila. So malalaman natin. Kasi iba't iba din yung klase ng atrial fibrillation natin. Pwedeng paroxysmal lang siya, pwedeng chronic na yung atrial fibrillation natin. Mostly sa kanila nagkakaroon tayo ng atrial fibrillation kapag merong ongoing infection yung patients natin, or meron silang iniinom na medications na pwedeng mag-cause ng atrial fibrillation, mga yan. Or pwede rin cardiac causes talaga. Okay? And for your atrial fibrillation, isa sa mga most common causes natin ng AF kapag meron silang rheumatic heart disease. Kasi sa rheumatic heart disease, usually yung mga valves natin, stenotic sila or makakapal, nahihirapan yung flow ng heart. So kapag nahihirapang dumalo yung dugo sa ating sa ating valves, atrioventricular valves, ibig sabihin yung pressure dun sa atrium natin tumataas. So kapag lumalaki yung right and left atrium natin, mas prone sila na mag-fibrillate. Okay? So yan yung mga qualifiers natin for atrial fibrillation. Usually, minsan, pag nakakita kayo ng ganito sa ECG, tapos dehydrated lang pala yung patient nyo, after nyo siya i-hydrate, pag ulit nyo ng ECG nila, wala na silang AF. So yan, maraming causes ng atrial fibrillation. Pero very good for sir to he was able to identify na atrial fibrillation.
And since this is just a basic ECG, maybe kung meron pang session, then we can discuss other abnormalities like commonly PVCs,
Yes, Doc.
ABCs, and then yung mga AB blocks. So, ito lang yung basic lang binigay na ni Dr. Mariano. So, kung okay kay Ike, kung mag-set ulit, okay lang naman.
Noted,
Yes,
Doc.
Doc.
Noted pa.
For now, I suggest na i-practice yung basahin lahat ng mga makikita yung ECG during your free time. So, pwede ko namang i-send kay Sir Ike tong slides nito, lalo na dun sa computations, dun sa first part, kung paano gagawin. Yung systematic approach in interpreting your ECG. Para at least, kung may makita kang ECG, di computin mo yung rate, tingnan mo yung rhythm, tingnan mo yung axis, tingnan mo kung merong mga hypertrophies yung ECG na yon or miscellaneous findings. Sulat mo lang para lang ma-practice mo yung ECG reading. Then, after that kasi kung na-practice mo na yun, then I think we can proceed na with other abnormal findings like yung sinabi ni Dr. Kelvin, mga PVCs, PACs, mga yan, mga AV blocks kasi mas mahirap na siya. Mas nakakalito na siya kapag diniscuss natin yung mga yan.
And ang advice, if you want to have a practice of ECG reading, do it among your among your units kasi ang hirap naman mag-verify kung sarili mo i-verify mo. Okay? So
Yes.
do it grupo kayo para alam niyo mag-discuss kayo kung ano meron at wala.
Yes, Doc. Thank you, Doc.
Okay.
So that's the end of my lecture for today. So just to declare my references from our books, itong mga references natin sa tiniscuss ko sa inyo na basic ECG reading. So that's all, everyone. Thank you for actively participating and for listening. Kahit na very taxing yung lecture natin and very overwhelming. And I hope you learned a lot from this lecture today.
You're welcome po, Doc. Our heartfelt gratitude to Doc Shanong for that very informative and interactive learning session about basic ECG interpretation.
Thank you also to Doc Kiko, Dr. Kelvin ko. It is indeed a wonderful experience to learn, especially when this learning is happened to be instrumental for our daily tasks.
We are frontliners and it is our responsibility to respond promptly with a high precision of knowledge and skills, especially the urgent events of in our facility. Again, Doc, maraming salamat po.
You're welcome po, sir. Thank you. Thank you for inviting us today and for sharing our knowledge dun sa ibang mga kasama nating frontliners.
Thank you, Doc. To express our gratitude to the guest speaker, a certificate of recognition and a simple present will be provided. But first, allow me to read the content of the certificate. Okay, certificate of recognition is hereby awarded to Christian Mark B. Mariano, MD, as the research speaker on the course Basic Electrocardiogram Interpretation, date June 24, 2022, with contact hours of 2. Signed by yours truly, Enriquez R. Cayaban, RNLPT MEN, Training Officer, and Dr. Christine Agata N. Untalan, the Chief of Hospital. Thank you very much again, Doc.
Thank you, sir.
To our dear attendees, you will be receiving an electronic certificate after answering the Google form for your attendance, quiz, and feedback survey, which will be flashed on the screen in a couple of minutes. For now, let me read the content of the certificate. Certificate of attendance is certified that your name has attended basic ECG interpretation, date June 24, 2022, signed by Mr. Enriquez R. Cayaban, RN, LPT, MEN, our training officer, and Dr. Christine Agata M. Untalan, our Chief of Hospital. Thank you po. To formally end our virtual session, I will give the line to Ma'am Rochelle May Valdez, our Assistant Head Nurse Critical Care Unit, Santiago Medical City, to deliver her closing remarks.
Good morning, everyone. As we mark the end of our webinar on basic ECG interpretation, I wish to commend you all for having time out of your busy schedule. It was an excellent presentation, exciting ECG reading interpretation, and interactive discussion between our speaker, Dr. Mariano, and Dr. Kelvin, and the participants. Therefore, I conclude that the objectives of the webinar has been completely accomplished. I'm hoping that we have learned from this webinar, and it will help us a lot in many aspects, especially in serving our patients. On behalf of Santiago Medical City Nursing Services Department, I would like to express my appreciation to all participants from Santiago Medical City, Flores Memorial Medical Center, Calang General Hospital and Medical Center, De Veras Medical Center, newly registered nurse, private sector nurses, students from University of La Salette, Northeastern College, and Isabela State University College of Nursing. Thanks to our training officer, Sir Enriquez Cayaban, who organized this ECG interpretation webinar, Sir Darwin Viernes, our infection control nurse, and Sir Mark Salgito, our IT department head. And special thanks to our speaker, Dr. Christian Mariano, for sharing his knowledge on ECG interpretation. Thanks as well to Dr. David Calvin Co. Jr. Doc, thank you so much. I hope we can have another webinar with you for first degree, second degree, and other types of docs. I would like to close my remarks and officially announce the end of the webinar session. Thank you for your attention and stay safe, everyone.
Thank you, Ma'am Rochelle.
Thank you.
Okay,
Thank
please
you.
access
Thank you,
the
sir.
QR code. Thank you, po. Please access the QR code or the link on the chat box for the attendance quiz and feedback survey. We do hope you have learned a lot for today's activity.
Just a reminder, please indicate your active and correct email address because it will be utilized in order to you to receive your e-certificate. Laging tandaan, ligtas ang may alam. Dahil sa SMC, we value life. Thank you, everyone.
Mabuhay ang Filipino nurses.
Thank you po. Please scan na po the QR code.
Oo, naririnig.
Start na?
Whoa.